Hello. So thank you for joining us. I'm trying to find Professor Da. I hope he had joined us so far. I cannot find his name. So please, Dr. Da, if you're already on the please raise your hand if you are already on the group. 1 second. Yes.
Yeah.
Yes. Hi. How you doing?
Hi. It's a hospital computer, so it comes as my first surname Day and then Mrig as my last name. I'm really sorry because I'm in the theater, so I'm logging on.
Thank you for joining us. It's a great pleasure having you, and we're really looking forward to hearing your talk. Dr. Osama Al-Ani is going to be joining us in just a few more minutes on the second chair. And please go ahead, Professor. You could go ahead and share your screen and do whatever you would like.
Can you read? Sorry, 1 second. Are you ready?
Yes, we're absolutely ready. Please go ahead.
Thank you.
So you could share the screen with the green button.
Yeah, that's what we're trying to do. It says you cannot start the screen share while...
Absolutely, yes. I fixed it. I'm sorry about that.
Just give me a second.
Great, yeah. Yep, we see it.
Thank you. Can you see it?
Absolutely.
Fine. Right. My name is Mrigankade. I'm a good friend of Osama Al-Ani, and I would like to thank Osama for inviting me to give a talk on this topic, and also to yourself, sir, for helping me to get to the forum.
Thank you for joining us.
Thank you. Thank you very much. I think it's probably the norm of the time now because of the COVID. We have been using Zoom Forum for quite a lot of teaching with the registrars and people around the world. What I'm going to talk is my philosophy on transoral surgery. I put down oropharyngeal carcinoma because I don't know the audience, but to be honest with you, oropharyngeal cancer, especially for early oropharyngeal cancer, transoral surgery, whether it's a robotic, laser, or other techniques, which I'm going to talk about, I don't think that's much debate there. Robotics, I believe, is better of the old techniques. However, you don't have any evidence for it. People use different techniques about it. I will also show you how my life revolved and evolved over a period of time. So when I joined, I was a consultant at Derby. I used to do laser operations, and then came the robot. We got onto the robot. I came back to Birmingham. I started back again on laser, and now I'm back on robot. However, for last month and a half or 2 months, we are not doing any robotic resections because of the COVID situation, but we are slowly starting our process. So I would like to give some background about what has happened with oropharyngeal work with regards to surgery, radiation, and chemoradiation, and what has happened with evolution of practice. And I will also touch base on the robotic surgery. I'll show you some skills. If the video works, good. If it doesn't, there are good slides there because I've done the presentation in front of the UK audience before, so I know what's available in my presentation. And then I will talk about some advanced applications. I'll talk about my work over the last 12 odd years. And I'll also talk about how to set up a robotic program if some of you want to set up a program. So this is a famous kind of paper from Florida. This is the paper which basically changed practice for a lot of us who are in the older age group, nearing 50s or above 50s. So this paper from James Pearson, and they looked at work on squamous cell carcinoma for oropharynx. And if I show you the tongue-based outcomes, and this is a North American academic institution study, with or without radiotherapy or radiotherapy alone, followed by neck dissection for oropharyngeal subsides. And they've got 6,400 patients. That's a huge number for oropharynx. And you can see for both group of individuals, the local control, the local regional control, the 5-year survival, 5-year disease-specific survival, they're same. However, you can see the severe complications in patients who had some surgery, followed by radiotherapy, etc., are more similarly for the fatal complications. So that's for the tongue basis. If you look at the tonsil, it's similar. So if you look at both group of individuals, the outcome is same, but the complications were more in the surgical arm. So it's almost like your VA trial for laryngeal preservation. You can see a group of individuals who have got oropharyngeal cancer. There's no HPV status in this because those days we did not do HPV status as a standard. And you're seeing a good result with non-surgical means. So, and surgery here, I'm not talking about transoral. I'm talking about the old-fashioned commando surgery where you do lip split, take the tonsils out, take the tongue base out, and put a flap, etc. And the, kind of neck dissections, etc. So surgery is not necessary. Now, you look at this trial, which again, the guys who are head and neck surgeons, they know this is a French study, and it's the results from 9401 French head and neck oncology radiation group trial, randomized trial, comparing radiotherapy alone with concomitant radio chemotherapy in advanced oropharyngeal cancers. And it basically made the chemoradiotherapy as standard of care. In this group of patients, however, it was interesting. And once again, they did not do HPV as a standard because those days we did not do it. You will find that the patients they had, they more look like a HPV negative patients. Why? Because they have larger primaries, smaller secondaries. Unlike you in HPV, which is my practice or some of your practice is, where you find big secondaries and small primaries. That's the classic of an HPV positive group. And if you look at them, their results are, again, 226 patients, and they've used radiotherapy in 70 grade 35 fraction, chemoradiotherapy 70 grade 35 fraction with 3 cycles, a 4-day regime of carboplatin and fluorouracil. And they found, and you can see from the survivals and all those things, basically, if you read the paper, it's very obvious that majority of the patients were HPV negative group of patients. And basically they proved that chemoradiotherapy makes a big difference. And based on this group of papers, I've just given you some examples of paper in that era between millennium 2004-5, where the pendulum has swung from that big surgery we all did, 12-hour operations, to chemoradiotherapy, where all we did was a biopsy and chemorad, obviously staging, etc. And that has been the standard of care, to be honest with you, even in British Isles. And even now, in our MDT, Penn Birmingham MDT, one of the biggest MDTs in the country, we still have chemoradiotherapy as standard of care. However, what I'm going to say to every one of you, there should be a transoral practice in bigger MDTs, larger MDTs, so that you are giving a choice to a patient. So this is a classic slide of John Almeida. Again, once again, those of us who are diehard head and neck surgeons, you've seen this slide. It's from 80s onwards to now, and you can see you have the big surgeries, then the radiotherapy came along, then the TLM, I'll show you, TLM came along from Steiner and Ambrosch, and then you had the tours from Weinstein's group, and then people like me and others have taken on. There are bigger names there who are doing a lot of work. And again, you had this VA laryngeal trial, which basically took quite a lot of the surgery out of the equation, and all these organ preservation strategies came along. Then the match analysis, which we spoke, and then one must not forget the HPV risk stratification, which is now part of the game. You know, there is no way, whether you're doing any management of oropharyngeal cancer, you can do without having an HPV status of some description. And that is very important to bear in mind. So what I am getting at, you know, I'm not saying that all of us should go back and do robotic surgery or laser surgery or the other techniques which are available. But what I'm saying that the patient should be given an option, and there are patients who are best suited for that. So I'm from Birmingham, and I always quote this paper, and I've always done so. It's the John Watkinson paper, and John used to say all the time when I was a trainee, he said, Mriganka, I have done patients where I've taken the tonsils out, I've done a radical neck dissection, and John Glaham, who is included in that paper, radio-oncologist, given radiotherapy, and patients have done well, actually. And I think they've got 18 to 20 patients, I can't remember, and they're all T1, T2, very select group of tonsil cancers almost. And that is there in clinical otolaryngology in 2002. So, you know, as I said, the evidence is still woolly. We haven't got a level 1 evidence. I'll come to some of it, you know, some of the evidence, and that's what the important things are. So now, robotic surgery. This is, all of us know, Gregory Weinstein and Bart O'Malley. They basically came out with this paper 2004, and they spoke about paradigm shift in head and neck cancers. FDA approval, all of us know that. It came out in 2009 for oropharyngeal cancers, early oropharyngeal cancers, T1s and T2s. That's very, very specific, guys. So this is a paper which I've always read and read with interest. Why? Because Chris Holsinger's paper talks about what I'm going to talk today. It's that steps of lateral oropharyngectomy. And it's why you will find why some of us don't like doing this operation. And you will find when you look at the steps of lateral oropharyngectomy, I'm not doing a tongue base here, then you'll find that robotics is probably easier to teach somebody, whereas the laser is little bit more difficult, and the learning curve is very steep. So this paper quotes this Hewitt's paper from France, 1951, classic lateral oropharyngectomy, which I'm going to talk about more in details. Now, the TLM, I can't go without talking about Steiner technique, which I used to do. And I have got patients in Pathos trial, which I'm going to quote a little bit more in detail so that you can understand where we are going and what will be there for future, and what are the key things you have to debate when you are in an MDT and tell your oncologist that we exist, mate. So Steiner technique is you cut through the tumor and get to the margin. I'll go into more in details in a second. This is a paper from Nova Scotia. Kishan Ubaisari is a consultant in Nottingham. He was our fellow in Birmingham, and he wrote a paper, How I Do It section in Clinical Otolaryngology, published in December. He called it Tomcat technique. I think the guys in Nova Scotia has been using it for a while, talking to Kish, and basically it's a transoral microscopic cautery-assisted laser tonsillectomy and tongue-based resection. The idea, if you read that, because I've done the review of this article as a reviewer for clinical otolaryngology, they're using the diathermy to cut the tissues where the laser wasn't good enough, and also doing the finite dissection with the laser. So it's a mix and match, basically. And this is a paper from Hull, Jamie Joes. His videos are online. I've not put the videos up. Anybody can look it up. And what he's doing is doing a transoral endoscopic video-assisted lateral oropharyngeal resection. So he's using a laparoscopic camera head, and he's doing a forehand technique. and he's published on 19 patients. His videos are there online, both for the tongue-based mucosectomy and for oropharyngectomy. So both are available online. And Jamie will not mind me putting on the presentation, but it's not necessary. You can Google it up and you can see that. And I think they are coming up with a larger series. And the main reason why Jamie and Lot are doing that sort of stuff, because the robot's not easily available in NHS, as some of you who have worked in the UK will know that. Now, why do we do transoral surgery, and how do you stand in front of your oncology colleagues? So one must remember, you're getting younger people, patients in their 40s and 50s, people who are non-smoker. However, in British Isles, we get people who are ex-smokers or current smokers, HPV positive, we should say. There's a typing error there. It should be HPV positive patients. And I've quoted a couple of the papers. There are many papers there. Again, they're not level 1, level 2 evidences. These are retrospective series, but it's very obvious that when you do transoral surgery, the robot or a laser, that the swallowing outcome is always better compared to just people giving them chemo-rad. And this is very important from Toronto as well. Again, they basically quoted that gastrostomy or G-tube rate dependence was lower with the TORS technique. This is a paper from Clinical Otolaryngology from Newcastle up in north of England, David Mickle, but it's Vin Palaris paper basically. And they showed very clearly with MDADI scores that, and there's a mix of laser and the robotic patients, that the swallowing outcome long-term is much better. And they have de-escalated their radiotherapy. Again, saying that, you can de-escalate in a trial form, and I'll get to that actually. You shouldn't de-escalate just like that. So these are the trials which are available in the market. You have the PATHOS trial in UK, and I think in Europe as well. ECOG 3391 P16 positive trial, which is based over at US. Orator trial from Canada, and the results are available, and I'll talk about that. Best of trial, which is again from Europe, and Moses study based, it's for a tongue-based mucosectomy. So I'm going to pick up on PATHOS trial. So what I have done, as I said, the chemoradiotherapy has become a standard of care in many places because it's a non-surgical means. Because people have accepted those very good evidence from our oncology colleagues. They've got more evidence than we have. We haven't got enough evidence in the literature to fight for existence. So I have enrolled myself, not I, we all have at Birmingham with PATHOS. It's for P16 positive. The inclusion criteria, I've mentioned TNM 7th edition, that's what we are using now. 8th edition one can use. I can't remember top of my head, but it's a T1 to T3, N0 to N2B nodes. So basically, patient who has got bilateral nodal disease, they're excluded. All patients have going to undergo transoral resection and a neck dissection, depending on what you have. And I have got patients with both TORS and TLM in the PATHOS trial. Endoscopic, I've never done that, but people are doing it. And it's based on swallowing assessment with MDADI and video fluoroscopy. It's very important that I go through it because this is how you're going to sell yourself. I'll show you why. So group A, R0 resection with no adverse features, you don't do anything, you observe them, and nobody will stop you because it's a part of a trial. And that has happened in Birmingham and other places in the country. Group B, which is the most interesting, T1 to T3 tumors, N0 to N2B disease, with evidence of PNI, so nerve involvement, vascular involvement, margins 1 to 5 millimeter. All marginal biopsies are negative in case of TLM. So if you look at the PATHOS, this is why I always say that TORS is a standard technique. You're doing a radical tonsillectomy, guys, or a radical tongue-based resection, whereas in case of TLM, you stop where the margin finishes because you're cutting through the tumor, and then you are basically going to do 8 marginal biopsies, which are clearly documented in the PATHOS trial document, and they have to be negative. And look at this amount of radiotherapy this group are getting. 50 gray, 25 fraction over 5 weeks. So way less than what we tend to give. And 60 gray or even in the control arm, they are not giving full whack of chemorad. 60 gray, 30 fraction over 6 weeks. So think about it. You avoided already chemotherapy to this individual. Already, you probably achieved a lot more than what would you achieve. Yes, for short term, this group of individuals will be quite a lot of pain, but they usually recover very well, actually. So, and then the other thing you need to bear in mind is group C, any T, which is T1 to T3, any N, which is N0 to N2B, with high risk factors such as margins less than 1 millimeter. Marginal biopsies are free in case of TLM. And ECS, remember, everybody now used to jump. I remember when I came to Birmingham, ECS, chemorad, you can randomize them to 60 gray 50 fraction over 6 weeks versus 60 gray 30 fraction over 6 weeks with concurrent cisplatin. So you can see how you are achieving a lot more than what we are, doing. And so therefore, the trial is the way forward, guys. And that's what I've done. So you can convince your oncologist to recruit and you do what is justified. Because I believe strongly, there are patients who suffer lifelong for chemoradiotherapy. So this is very important because you're going to be asking me the questions on this. Orator trial, Lancet Oncology 2019. And it basically clearly says that radiotherapy showed superior swallowing related to quality of life score 1 year after treatment, but the difference did not represent clinically meaningful change. And that is the comment. Why? Because they have 34 patients on each group. The other thing, which is, I must say, when I show you my results, I haven't done a tracheostomy for any transoral surgery patient. And they have done tracheostomies for those group of patients. So therefore, in nutshell, one, the power is not very high or strong. And secondly, they've done tracheostomies for the surgical group of patients. They ain't going to swallow very well. So that is why I take this trial with a pinch of salt. But you have to read this trial if you are debating your oncologist. Now, this is off the press, hot off the press. This is ECOG 3311, and this is the press release. And that makes me go really, really happy. In fact, so much so that I texted my head and neck oncologist, Osama knows Andrew Hartley, at 8 o'clock in the morning on a Sunday. And Andrew was saying, Mriganka, you've gone bonkers. I said, I'm really delighted because you can see this is a randomized phase 2 trial, ECOG, reduced post-operative adjuvant therapy in patients with intermediate risk P16 oropharyngeal cancer undergoing transoral surgical management, 2-year progression-free survival for the patients randomized to 50 gray versus 60 gray without chemotherapy. Think about that. Patients with low-risk group had no adjuvant treatment. So the guys who are got T1 tumors, good margins, small T2 tumors, good margins, no risk factors, they haven't had anything. It's like pathos equivalent, remember, and they were fine. So all arms, they have not talked about the chemotherapy arm, had 2-year survival of more than 90%. And the other important thing, and obviously they're going to phase 3 trial, and this is why I put this thing on, and it was published, I think last week in the press release. And it says, for intermediate risk groups, those with uninvolved surgical margins, less than 5 involved nodes, less than 1 millimeter of ECS, reduced postoperative radiation without chemotherapy was enough. And I think if you talk to anybody who is involved in pathos, whether it's Terry Jones or Meredith Evans, they're very clear what they want to answer. For HPV positive patient who's an ex-smoker, does ECS matter? Does margins matter? And I think, which probably will answer that it doesn't all the time. I'm not recommending that you're not going to give anything. What I'm recommending, you can de-escalate the treatment, which is, what Hisham Mehana said from the trial, which he came out with last year. And basically he commented on this as well, because it was with me yesterday operating very clearly that the de-escalate trial is completely different from the transoral trials which are available in the market. So that's one of the ways to start your program if you want to. Now, what are the absolute contraindications? Those of you who are starting, these are very important, and those of you who are junior in the forum today, but the guys who are senior or my level or senior to me, they know all this. So fixation of tonsil to the prevertebral fascia, no, no. Unresectability of the nodes, no, no. Mandibular invasion, no, no. Tongue base involvement greater than 50%, no, no. Pharyngeal wall involvement greater than 50%, no. Carotid artery, you're not going to do. And aberrant carotid artery is very important. So why I put this slide? Because remember, MRI scan is very, very important. And also CT contrast. Because what you want to know, the parapharyngeal anatomy, which is important for the oncologist. Those of you who do head and neck surgery all the time, they want to see, because they want to map out their radiotherapy field. But for us also, it's very important because we need to know where the carotid artery is. We need to know all these margins, etc. I'll go through the anatomy in a second. So, relative contraindications. Now, if you get comfortable and confident, you can do them. So if you have primary tumor contiguous with the neck disease, I will not do it, but it's your choice. Primary tumor extends to anterior to the angular mandible and hyoid involvement. I will let you guys decide. Now, I'm not going to go into this. This is mainly for very, very junior. 8 T's for transoral access, which is very important, which basically means that if you are doing transoral surgery, you must do the EUA, which is pen endoscopy. So the investigation, you want an ultrasound core biopsy, not an FNA, because the core will give you HPV status. FNA will not give you HPV status. You want a CT and MRI. And as I said, the evaluation of the upper aerodigestive tract by a transoral surgeon. And you need to assess whether you can get a good access. You don't want an operation which is you don't have a good access. So I sent a recurrent oropharyngeal cancer to Professor Pelleri last week because our robot is, not been used now. And he was very clear, Mriganka, can I do the EUA? I said, I'll absolutely be delighted, but I know the access is very good. So this is what we need, you need as well. It's called FK retractor. You can do a transoral resection without an FK retractor, but you can't do tongue-based resection without that. You can get away with it, but you need this instrument. It's, I think, £15,000 in UK sterling. And this is how you built it. And you should, when you do an EUA, you should make sure that you put the gag in. And the key is to make sure that you have that access. Also, one thing you need to bear in mind is the vicious instrument. So be gentle with it. And obviously, if you're doing transoral work, let the trainee do the neck dissection. You can do the transoral bit. Again, you can't forget this. All of us know what it is. You can do most of the tonsil operations with this, actually. So this is a classic, you can see the cursor. This is a tonsil cancer, and this is a huge, big node. And you can see the great vessels there. You want to see whether it's gone out, whether you can cut it out or not, which is very, very, very important. So this is not involving base of your tongue. This is well localized. And this is a classic case where you should be able to do it. Now, you can do it if it's part of a trial, if your oncologists are very strong. And if they're part of the trial, then you can put it in the pathos or ECOG or whatever, and you just get on, because they will say, I'm going to give chemo-rad anyway, because there are some signs of ECE there. You can debate. If it's a part of a trial, then we can go into whatever arm of the trial it goes. So key is to exist and be scientific. You just don't want to operate if not necessary. So this is where you're not going to operate. So if you look at my cursor, this is, more than 50%. It's gone to the other side of the base of tongue. I'm not going to do any transoral operation on this guy. If this patient is suitable, patient is going to get chemo-rad, and possibly the swallowing will be rubbish for the rest of the life. And this is what I want to show. This is one of my first cases in Birmingham. This patient had a T2 tonsil and had tonsillectomy. And you can see post-tonsillectomy MRI scan. There is no sign of any tumor whatsoever. And there was no lymph nodes. So this is an HPV positive 67-year-old lady who had a tonsillectomy by one of my colleagues at QE and was sent to me. I did a fossa resection. I did a neck dissection because it's a T2M0, M0. good clearance. I haven't given any treatment to this lady at all. The neck dissection we do because we want to control the vessels, and I'll go through that in a second. So that's something you need to bear in mind. So it has to be carefully planned. So don't dive in without doing anything. I'm not going to dwell too much, but it's very important for those of you guys who are trainees in the forum. You need to know the anatomy very well, and this is what it is. I'm going to go a bit more further forward now. The blood supply, again, once again, guys, you need to know the blood supply very well, because otherwise you will get into trouble. So the key is to control the bleeding in the transoral part of the operation, in the parapharyngeal part of the operation, and in the neck part of the operation. That is how you become a good transoral surgeon. Otherwise, don't do it. So, anatomy in layers of oropharynx. So you need to remember, you have your stratified squamous epithelium, then submucosa, then you got pharyngobasilar fascia, and then you have the superior constrictor with some middle constrictor and buccopharyngeal fascia. So you need to know those fascias. Now, again, this is the tongue base. Again, some of you are very, very near, but lingual artery is very important to control. Again, you need to be comfortable controlling it in the transoral part of the dissection, and you also obviously can control in the neck part of the operation. You also need to bear in mind that you don't damage the hypoglossal nerve when you are operating. You also should preserve the glossopharyngeal nerve if you can, but sometimes you have to excise it. So this is these are the slides from Pittsburgh from my colleague and friend Uma Duberry. Some of you know, he's probably one of the greatest exponents of robotic surgery. And this gives us a beautiful view of your parapharyngeal space. If I can get the cursor there, where is it gone? Yeah, so this is, you need to know your friends are your styloglossus and stylopharyngeus muscle. You need to know where they are, because that's how you're going to save yourself from damaging any great vessels. So if I go forward slightly, so this is a good documented, documents of your stylopharyngeus and styloglossus. And key is to know where the external carotid and internal carotid vessels are. So this is very important. As I said, you need to control the vessels in the right plane. Ascending palatine artery is there. It's called vessel of Sod. It always causes a lot of problem. So you need to know the variations of ascending palatine artery. And it comes out of facial artery and it crosses anterior to the styloglossus. So when you're down there, I'll show you in my video stroke slides how you tackle it. So you need to be bearing in mind that you will encounter them and you need to ligate it properly. The other variation is of the facial artery. It goes between the styloglossus and stylopharyngeus, and it can come out of external carotid artery. So again, it goes between the styloglossus and stylopharyngeus. And it is very important. This is where people get claustrophobic, and people who aren't comfortable doing this operation, they will get into trouble. So you need to bear in mind all this. Now, this is something which can be scary. So you need to remember that if you are staying medial to styloglossus and stylopharyngeus, which is your styloid diaphragm, you're fine from the carotid vessels. But this variant is observed in new anatomy books, which is for the transoral anatomy. And you can get what we call carotid knuckle, which basically goes between the diaphragm. I'm talking about external carotid knuckle. And you think about it, you go through it, you will have a bloodbath. So, and to be honest, this is one of the most important things you need to remember. The other thing, which is there is a new paper from Stoke-on-Trent, one of my colleagues, Ajit George, Osama knows. He's done a beautiful paper on transoral anatomy, insider anatomy, which is published in Head Neck Journal. And basically, he also found something called aberrations of facial artery, which comes out between those muscles. And you need to bear in mind. So what I'm getting at, don't just dive in. You need to dissect layer by layer, which I'm coming to now. So the styloglossus and stylopharyngeus, my sincere apologies for those of you who are very senior, but I'm just going to go through them again. The styloglossus muscle arises from the anterior and lateral surface of styloid process. and passes inferomedially between the ICA and ECA to insert into the lateral aspect of the tongue base near the dorsal surface. You need to remember that. The ascending palatine artery crosses over the inferior third of the styloglossal muscle, which I told you, and is closest to the tongue. The stylopharyngeus is, on the other hand, is a long, slender muscle, cylindrical, and is flattened down below. It arises from the medial side of the base of the stylocrosis, passes inferiorly along the side of the pharynx between the superior and middle pharyngeal constrictors, and spreads out beneath the mucous membrane. The glossopharyngeal nerve, remember that, runs on the lateral surface of the muscle and traverses it to reach the tongue. So you need to remember that, because this is where the crux of the matter for transoral surgery. And this is where, especially the styloglossus, which I've come to, is where you get the margins positive. Because if you are getting margins positive, you ain't going to do anything right. So why do we preserve the glossopharyngeal nerve? Again, my apologies, those people who know very well, it preserves the sensation of the tongue and pharynx. It's a motor function to some of the superior constrictors. But sometimes you have to take it out because of, it involves the cancer resection. So steps of lateral oropharyngectomy, and I think this is the most important slide. You cut through the pterygomandibular raphe to identify the parapharyngeal space. This is how you're going to get a control with help of medial pterygoid. You separate the constrictor from the parapharyngeal fat, mobilize the superior tonsil pole with adequate cuff of tissue of soft palate. I'll go through with the slides later on. Careful dissection of the parapharyngeal space, free the stylopharyngeus and the constrictors. Adequate mobilization of the tongue base and the deep space between the tonsil pillars. And then this is the important message, resection of at least 1 centimeter of the styloglossus tendon. This is why people get scared, because of that artery, as I spoke about. And then you have to make the index cuts in the posterior pharyngeal wall to complete the dissection down to the prevertebral fascia. And what you are doing, a standard operation, which is what you can do with a robot. You can't do this with a laser. You can if you're really, really good, but I don't think I can. You can do it with your Tomcats, or you can do it with a Colorado needle, as Ian Ganley's video from one of his Sloan Kettering Memorial videos shows. But having saying that, you should be doing one technique again and again, so that when it comes to a very complex case, you're good at it. And that is what my message is going to be. So this is the most important thing. All of us know this, pterygomandibular raphe, but that is where you need to make the cut. Otherwise, you lose the plane. And I've seen, and this is from, I think, Hinney's article, which is very clearly demonstrates, where exactly the vessel is and where is the medial pterygoid muscle is, because the medial pterygoid muscle is very important, and that is where you get the plane. That's the fat, and those are the vessels. And you can see he's pushed it medially, and that's your right side tonsil. And this is one of my patients where I have made the index cuts on the pterygomandibular raphe, and you need to go higher. I'll show you another one where this is the patient who had tonsillectomy before, and those is the index cuts which I've made. And I make sure that I go a bit higher. You talk about nasal regurgitation, you have to counsel these patients. Usually, if you have a very robust swallowing rehabilitation with help of a very highly skilled, highly experienced speech and language therapist and good analgesia, you can get rid of it. But it can stay, last for a wee while. You have to counsel those patients carefully. So that's that. Now you find the plane, and you can see I'm finding the pterygoid, medial pterygoid muscle. You want to find the fat. Now, the important thing is don't grab the tissues anytime. What we talk about, you hold the medial part of the tissue like that, almost like open the jaw up, push it, sort of traction, counter traction, and gentle dissection of the tissues. So if you go down now, you can see I'm finding the fat, and this is a beautiful demonstration of medial pterygoid muscle. And look at how high I am. I'm trying to get the sort of parapharyngeal space higher, and I'm in control because I know that the carotid vessels will be where my cursor is. So going forward, this is where it is. So you can see that's the fat, you have to find, once you find the fat, the operation becomes easier because that's your constrictor there. And I progressed with my dissection. And you can see, and I'm using my assistants. So my assistants uses 2 pediatric suckers. So you got 4 hands in there to getting the retraction. I'm at no stage I'm grabbing any tissue if I can. And it takes a little longer, so be it. What you want to do, achieve enough hemostasis possible. And I tend to do the neck dissection before my transoral operation if I can. Yeah, so that is very important because your carotids are underneath that. So going forward, as I said, you need to find inferiorly your styloid diaphragm or styloglossus muscle, which is very important. So it is what this is, again going back to other way around. Let me get the cursor. Where is it gone? Yeah. So you can see that's your styloglossus muscle. From again in his paper is very clear. That's your branch of glossopharyngeal nerve, and that is your medial pterygoid, and that's your fat over the carotid vessels. So you have to define the styloglossus muscle, otherwise you'll get a margin. You have to have a centimeter margin. And what you need to do, as I'm doing here, once again, let me get the cursor over. I am taking layer by tendon, muscle by muscle, the styloglossus muscle, so that I am getting that centimeter clearance for us to achieve that centimeter clearance. Otherwise, you ain't going to, you end up going to that arm 3C, or C for cat, of the pathos trial, which you don't want to do. Now you're coming near, you can see I've taken another picture where basically, again, I'm doing the same thing. I've already done the index cut for posterior pharyngeal wall. And that is the ultimate outcome. So you can see the shiny bit of your prevertebral fascia. That's the fat over the carotid. That's your bit of the styloid muscles there. That's your base of your tongue there. And that's what the ultimate result. So if you look at again, going back to, I'm grateful for these pictures. You can see medial pterygoid, the great vessels with the fat, and you need to find the shiny prevertebral fascia. Otherwise, you haven't achieved any dissection. You also want to go slightly higher on your pterygomandibular raphe. People don't, and that's when you get into trouble because you're not going to find the plane. And if you don't find the plane, because there are videos from the famous surgeons online, and it's interesting to see that they haven't found the parapharyngeal space proper. I don't know how they're doing that operation because I find it claustrophobic if I'm not seeing the fat of the parapharyngeal space, because then you know where the carotid artery is. It's very important. So you need to, and unfortunately, this is one of the pictures I've found. I've got multiple other pictures, but this is what I want to show. What I want to show is that you can load it up in a beautiful board, which I use from the breast surgeons, and you can take a picture. And to be honest, when I came back to Birmingham for some transoral resections, I went down to the path lab and helped them to trim the specimens. Because if the guys are not used to it, they will always going to call the margins. And you have to be around with them to show them where the tumor was and how to cut the specimens. It's very important. So this is a paper again from Italy, which basically they've classified lateral oropharyngectomy, type 1, type 2, and type 3. It's the presentations there online, so I'm not worried about it. So what it is, it's basically redefining, or rather defining this new technique or an old technique, which has been redefined by the transoral surgeons so that we can report, and there should be an uniformity of reporting. And also we can stand up in the MDT and say, this is what I've done. So tongue bases, I think tongue-based operation completely reliant on the fact that you need to remember that you have, palatine tonsils on sides. You need to come to circumvallate papilla and posteriorly pharyngoepiglottic or glossoepiglottic folds. You need to control this vessel. This is your lingual artery. It's there. All of us know where it is. You also need to know the hypoglossal nerve is there. You can't damage it because that's a disaster. So again, once again, this is Another picture, I think, again, we all have seen these pictures before. And this is again showing a classic example of where the lingual artery, and the name of the game for tongue-based resection is controlling lingual artery. If you can control it, that you've achieved half the operation. So the description is simple. You incise through the posterior third of the tongue, then you find the midline towards the vallecula, identify the vallecula, you will know the depth, and then you do the lateral dissection, clip of the lingual artery, which has to be done by an assistant if you are not on table, and you can clip off the lingual artery even in the neck. So this is a picture, I think, just shows what usually you do in a tongue-based operation. What it is, you can see this is a tongue-based resection for a T1 tumor. And see, the best thing about it is that this lady is one of our first patients in Birmingham. This is your tumor, good resection margin. It's a T1 tumor, no nodes. We're observing this lady and she's fine. And the swallow rehabilitation, we need to be careful. I'll talk about it in little bit details in a second. Now, it's important to reduce a catastrophic bleed because one of the most important factors in transoral surgery is to reduce the bleed. Even if you look at the Pittsburgh paper, where they have done 236 patients, they've got a randomized paper in that, not rather randomized, looking at how things are worked, paper where the patients have ligation, non-ligation. They said they've reduced the catastrophic bleed, but they haven't eliminated the bleed, which is important. And ideally, you should ligate ascending pharyngeal, lingual, and facial. If you can't find them, you should ligate the external carotid artery, which is very important. So this is one of my pictures. You can see, if I can get my cursor going, that's your hypoglossal nerve. That's your ascending pharyngeal artery. You don't find it always, by the way. That's your lingual, that's your facial and lingual there. And you ligate them one at a time. This is your jug. This is your common facial artery. And you've done a neck dissection 2, 3, 4. That's what we tend to do. I don't do 1. That's the practice. And you ligate the vessels beforehand, before doing a transoral resection. So this is something I will never forget. I think Osama knows, I lost a patient who died from secondary bleed post-transoral robotic surgery for a T1 tongue-based stroke inferior tonsil tumor. And what we debated in that, from this slide from my colleague from Pittsburgh, that there is a variation of ascending pharyngeal artery. And those of you know that sometimes ascending pharyngeals are absent. Sometimes, most of the time, it comes off the external carotid artery. However, you can see there are variations of ascending pharyngeal artery. So don't get nervous when you are dissecting the carotid system and you can't find the ascending pharyngeal artery because it may be absent. And I sometimes don't go for external carotid artery ligation. I ligate the lingual and facial and stop there, saying that you're duty bound to do whatever you feel. But when I had the debate in front of the coroner, as you know, in UK, you have any sort of unnecessary death, you go in front of the coroner, you get asked 45 minutes of questions in a witness box. And the debate was based on what I just said about ascending pharyngeal, because our tie was in the right place. However, because of the variability of ascending pharyngeal, you can't really reliably say that you've done it. And the other thing you have to remember, if you look at a Pittsburgh paper, they're reducing the bleed rate down to less than 4%. They're not eliminating the bleed rate. And therefore, you need to bear in mind that you are there to help the patient out if necessary be. So tongue-based mucosectomy, this is a paper by Hisham Mehana. I'm one of the authors in that. And it's very clear that when you do mucosectomy, you pick up the cancers. And that's mainly for HPV positive, not for HPV negative cases. And you can see in 64% cases, you're picking them up, whether you're doing a laser or a robot, in fact. And it's, as I said, HPV positive cases. And it's very important. And there is another trial which has come along called Moses trial, which I mentioned. It's from Royal Marsden, led by Professor Paleri. And they're, in fact, probably won't be helpful for now, but they're doing different sort of trimming of the transoral mucosectomy specimens to see if there is any microscopic disease or not. And that is beyond what we are doing now. So this is a classic picture of one of my patients who had a tongue-based mucosectomy. Look at the size of the specimen I've given to this guy. And this is a guy he's of Northern African origin. He doesn't smoke. He came to my colleague with a cystic lump in the neck. He's 42 years of age, non-smoker, non-drinker. And what happened? A core biopsy wasn't very successful. Open biopsy, SCC, P16 positive, PET scan negative, MRI negative. I go in, obviously he had a completion neck dissection when I did a tongue-based mucosectomy. He had tonsillectomy in his childhood, and the cancer was here. And it was a 1.3 millimeter cancer, take my point. And he's probably the last one I did because I went back, and by definition is a T1 tumor, N1 disease. So I went in and revisited the area, did a revision or basically I did a second look procedure and took that area out, and he hasn't had any radiotherapy or chemoradiotherapy. Had it been not for the TORS or TLM, this guy would have had chemoradiotherapy, because we would have found this tumor, which has got the margins involved. He's got N1 disease. You're going to ultimately going towards chemoradiotherapy. So you can see if you have a transoral practice, you can avoid this 42-year-old gentleman a extra operation. He's a fit and healthy guy, and he should be observed, and he will not have long-term sequelae of chemoradiotherapy, which is what I'm getting at. So this is you need to bear in mind when you consent a patient. Hemorrhage rate, 3 to 10%. You can't run away from it. There is a mortality associated with it, aspiration or an asphyxiation. And that's why in Orator trial, I think, if I'm not wrong, they did some tracheostomies, which I don't do, and I haven't done any. Salivary lick, it's a paper from Adelaide, from Suren Krishnan, and he talks about the salivary lick. However, if you look at that paper, you'll find they're doing 1, 2, 3, and 4 level neck dissection, which is not my practice, which is not the practice in UK. But if you do level 1 dissection, you are losing that buffer of a submandibular gland, which basically, if you go through the parapharyngeal space, gives you that buffer. And he talks about this posterior belly of digastric flap, etc. We don't need to use that because in UK, we don't do number 1, a level 1 dissection routinely. Now, this is what I need to, I'll go through a few issues with regards to TORS program. You need training in terms of fellowship. You need a robust business case if you're in UK. I don't know how in other parts of the world, which is very important. Case observation is the key, because some of us who are very senior, being a consultant for 12, 14, 15, 20 years, you pick it up in no time. Console time is very important, because I've been to that course in Strasbourg twice, once from Derby, once from Birmingham. My recent experience is interesting, because if you don't have console time, they will not let you go through the course, because you have to score more than 90% on their certain console modules. If you don't do that, they are quite skeptical about it. But when I went from Derby in 2013 or 14, when I went, they were not fussed about it. But this time around, last year when I went, they were very clear. They give you some tasks, and if you haven't spent time on console, you're not going to score 90% or more. Cadaveric dissection goes without saying you need to do that. Dry run is very, very important, because so everybody needs to know what you are doing, and even your HCA, which is healthcare assistant, which is the lowest form of nursing in UK, they need to know what you're doing. It's very, very important, and that's why going back to doing the same technique again and again. Proctored cases, it's important how you deal with it. Sometimes some people do it in one case and they say fine. This time around, however, I made sure that the proctor came every single time I've done a newer technique. So when I did my tongue-based mucosectomy, he was there. When I did my lateral oropharyngectomy, he was there. Even though I'll show you, I've done probably a lot more than a lot of people in UK. Probably there will be 2 or 3 people who have done more transoral work than me. I still want it to be inch perfect correct with my governance side of things, so that I have gone through the hoops. I've got the right report from my proctor saying that I am safe to do this operation. Maintaining an audit, and ideally you should get the proctor back after 20 cases, which is very, very important. Now, the patient selection is very important. It's the key to the whole process. In the beginning, you should do early oropharyngeal cancers, T1, T2s. You should be part of a trial, then nobody will say anything. And tongue-based mucosectomy should be offered to everybody who has got an HPV cancer. If you don't do it, you're missing out on cancers because you are nearing 70% detection rate. And when the Moses trial comes along, I know it'll be way more. Robotic team is very important, which includes the anesthetist. You know, the guy who anesthetizes for you. We have the debate. I'm sitting in a hospital called Solihull Hospital, which again, Osama knows is one of the smaller hospitals. And we started the hospital because of this hot cold business where, you know, the hot means where a lot of COVID cases, cold means where there was no COVID case. So when we started the work at Solihull, we made sure that we have an airway anesthetist, not an ENT anesthetist. Not all ENT anesthetists can deal with airway. So it's very, very important. And also you need a pain team, depending on, obviously it's led by an anesthetist most of the time. And that is very, very important because majority of our programs have got very robust pain protocol, which we also have. We learned from Leeds, we learned from Hull to see what they're doing, because otherwise these guys are in severe pain and they will not swallow whatever you do. The theater team is very important, and speech therapy, as I said, the swallowing assessment is very, very important. You want to get rid of those patients from hospital within 2 to 3 days. You don't want to, if the patient's staying longer, then you have not achieved. You rather do the big operation. And CNS input, which is the Macmillan nurse or clinical nurse specialist in blood, is very, very important. So those of you, again, my apologies, people know all the slides, but that's a theater layout for the guys who haven't done robotics, not seen any robotics in their lifetime. This is, again, a slide picked up from the Google, but I'll go through my slides, which is, again, remember the robotics are for abdominal surgery, for urology mainly. So you are trying to do an operation with an instrument which is meant for a different type of operation. So you have to reconfigure and adopt. And this is the important thing. This positioning is very important. Once you get this positioning, your docking time will be down to 5-10 minutes or even less. So this is the classic positioning. This is what one of my patients, and you can see the angulation. And so what we did is we have put a permanent marker in the robotic theater so that we know where to put this thing in. So that, you know, next time around when we come in, we know where. We just close your eyes and put that thing there. The nurse assistant can put that thing there, which is very important. So you also need a dual console. This is with me and Professor Balazs. He's now, I think he's moved out of Hamburg to Frankfurt. So he came in, I think, 2014, 13 to help me with the case. And you can see it's a dual console, and most of you should have a dual console because then you can train. 2, if you get a proctor, you can help each other. And 3, you can be 2 of you doing the operation. Part of it can be done by one, part of it can be done by other, which is very, very important. I don't have a dual console robot over in Birmingham, but that'll be a great thing if we get a dual console. This is the arrangement inside the mouth for the robot. You can see in the middle, the camera system, and then you have got the instruments on each side. So I will go through the instruments. That's again, this is what is important. You need to put the FK retractor. You need to suspend it. This is a suspension there. However, nowadays we have a suspension. It's almost like a laparoscopic instrument, which is, I think, devised by Olympus or Storz. I can't remember top of my head, which also reduces the bulk. You want to reduce the bulk and minimize the amount of instruments. I always put nasal tube. I don't put an oral tube. I think there are talk about people stitching on one side. I don't. I've not done that in my lifetime if I can, because you want to reduce the number of instruments in the mouth if you can. So it's important that you have a robotic instruments. I'll go through one at a time. Head and neck tray, tracheostomy tray, tonsil tray, etc. So 5mm cannula is very important because you need a 5mm instrument for your spatula, which is from whichever side you want to do. If it's a right-sided operation, I use right side 5mm. And then you need a monopolar cautery, which I use for the side and the 5mm side. And then you need a Maryland dissector if you are using it. I don't use it. And you need a bipolar forceps. It's 8mm forceps. You can also get a 12mm forceps. So bipolar forceps can be on your left-hand side if you want, whichever side your dominant is for the non-dominant side. So you should have this because it's important. It reduces the amount of instruments you have in theater. These are the robotic instruments. You have a tray for that. And this is my first case as a robotic surgeon. You want to choose the easiest operation known to mankind because you'll be worked up for this operation and everybody's looking at you. So wise to pick up a case like that. This is what I did. And you can see this is the outcome. And it doesn't take very long because most important thing when you're doing this operation for the first time, docking will take a long time. You've been observed by a senior clinician. You are also being observed by everybody else. You want things to go very well, and therefore you would like to have the simple operation possible. So this is my Derby experience. I've included Sean Mortimer because he has played his role in this. 36 patients with oropharynx, and you will see that HPV positivity was low because in the beginning, we never did any HPV positive, HPV status. However, also in the beginning, I think we were slightly not been careful with selection. We wanted to do the operation. And you can see there are a lot of there are 1 or 2 T3s and T4s there. Now I think I'm super selective and I'm only doing T1s and T2s. So this is my Derby experience from mucosectomies. I've done 12, supraglottic laryngectomies some. I've also done some parapharyngeal tumors and I've done some benign lesions. If you look at my Birmingham experience, again, I've been very, very careful because I've come to a new MDT for the last 3-4 years. They are very chemoradiotherapy strong, and I have maintained that I've done all the HPV positive, but I will have some adventures in the near future. So if you look at my overall outcomes, it's as good as anything. This is again, disease-specific outcome. I'm very happy to compare with anyone. I've got this in one of the publications somewhere in one of the journals. And so what are the advanced applications? Advanced applications are for recurrent oropharyngeal CA or hypopharyngeal CA. To be honest, in UK, only Marsden, which is Vin Paleri and Cyrus Carawala does them. I think hopefully we'll be able to do that. You should be able to do it with free flap. I think it's more for insetting of the flap rather than anything else. Supraglottic laryngectomy, I think once you've done quite a lot of oropharyngeal work or you have got a very good experience in laser surgery, then you should do that. Parapharyngeal tumor surgery, in my mind, you really have to be good and you need to give yourself a lot of time. It takes 3, 4, 5, 6 hours sometimes to do this operation. And that you need to bear in mind. Thyroid, parathyroid, I've got my own reservations and neck dissection. So from my point of view, I personally feel oropharynx, supraglottis, hypopharynx selected group of patients, recurrent cases, parapharyngeal surgery, they are the ones where we should be doing them. And we should be doing a robotics resection in a high volume center so that you can have sort of throughput of at least 4 or 5 cases a month so that you are not de-skilling yourself. Because remember, you'll be doing this operation with another consultant colleague of yours. You're not doing on your own most of the time. I think there's only 1 or 2 surgeons in UK who does the robotic surgery on their own. I mean, they do it with a registrar or a fellow. So this is my end of my lecture. I would like to thank everyone for listening to it. And I would also like to thank Uma Duburi from Pittsburgh and Kishan Ubesari for Nottingham to sharing the slides and some helpful contribution. I'm happy to take some questions if you want.
Yeah, thank you very much, Dr. Dutt. This is a great talk. Appreciate it. Osama keeps on sending me messages apologizing for him not being able to join us because it's
all right. That's fine.
seeing in the clinic. But I just have a quick question myself. Could you describe to me the extent of the tongue-based mucosectomy, like how much tissue you take? What's the anatomic limits of your procedure?
Yeah. Very good question, and this is where the robot comes on its own. Because what you want to dissect out in an HPV positive patient, all the lingual tonsil. So exposure is important. So you go from the circumvallate papillae to the vallecula, and you want to make sure that you removed every single bit of lingual tonsil, and which, as you can see from my picture, I divide in the midline and take one part first, and then go to the other side. So idea is to don't leave any lingual tonsils. Because as I showed from one of my cases, there was a 1.3 millimeter cancer. When a guy who has no risk factors, The only thing, he was HPV positive. So when we, that is my take on, yes, you can do this operation with a laser, with a microscope, but my reservations, having done both laser and the robot, you can think about it. Laser, you're doing a 3-dimensional picture. Robot, you got a, laser, you are using a 2-dimensional picture. Robot, you are using a 3-dimensional picture. So you're going to get better yield, and that is very important. So I go from the circumvallate papilla all the way down to the vallecula, and making sure I've removed every single bit of the lingual tonsil.
So you get down to the muscle?
I don't get down to the muscle. Good question. I'll answer that as well. So there is among us, try going down to the muscle on the side of the cancer. The idea is, as you've seen with my patient, which was a 1.3 millimeter tumor, going back to giving example, I've got a few other examples, where if you take the muscle out a little bit, you might give that patient a margin. The reason I don't do is that if you touch the muscle, the swallowing, I always worry about tongue-based operations with regards to swallow and post-op swelling, etc. And therefore, I try to do it in a minimalistic way if I can.
There's a question from Dr. Bukhara from India saying that how many cases takes to learn robotics, and like what's the learning curve question really?
Yeah, thank you very much. I think learning curve for robotics is less steeper than learning curve for transoral surgery or any other surgery like Tomcat or the stuff I spoke about, endoscopic technique. I think there is no hard and fast rule, but as I said, if you have a proctor back on 20th case, roughly there or thereabout, you can be assessed again. And I think the assessment has to be robust, because if I look back, I've started 2 programs, very unique in that. And the first program, I think it was more of a, fine, somebody's seen us, signed us off, and it was very obvious from the minute one that I've done a lot of laser work, and therefore I could transfer the skills. However, second time round, the governance side of things, i.e., assessment was much more robust, and I was happier with that. So I think 20, 30 cases, you should be able to do oropharyngeal stuff. For doing hypopharyngeal and laryngeal, I think you need a lot, I think more than 50 cases. That will be my view. But, it'll be interesting to see where we get to, because it's a new technique and we are having a lot of papers out, and it'll be interesting to know where we get to.
Can I ask you how long of a waiting list you have, or you don't have a waiting list? You just take the patient.
So we do not have a waiting list for a robot because remember, I get to do only cancers, and I'm fortunate enough to part of Birmingham, which is the 2nd city in the country. The city itself, a 1 million population. And if you look at the West Midlands conurbation, you're nearing 5 or nearing 8 million. And we are the only center other than Coventry where Osama used to work. So the case, going back, I think the robotic practice should be available in a bigger center. Therefore, we have no problems getting cases. I never had any problems having cases for my lists. So I haven't got a waiting time, but waiting time is not there because it's mainly because we're doing cancer work.
Thank you very, very much. Really appreciate you being with us. So we're getting a lot of compliments on the chat line about your talk. So thank you. We really appreciate what we've heard. So thank you guys, and we'll see you tomorrow, same time. Have a nice evening.
Thank you for inviting me.
Yeah, pleasure.
We'll catch up whenever. Thank you. Thank you. Pleasure. Bye.